Today, our session is about the evidence-based consensus statements of the Philippine Heart Association and the Philippine Society of Endocrinology, Diabetes and Metabolism approach to lowering the cardiovascular risk of individuals with type 2 diabetes. I'm Dr. Bien Matawaran. I'm an endocrinologist. And these are my disclosures. And for this session, we'll be highlighting the epidemiology of diabetes in the Philippines, cardiovascular disease and diabetes. So as we put this consensus statement into context, we'll go through the methodology of the development of the consensus statements. I'll be discussing the consensus recommendations for the anti-diabetic drugs of choice for individuals with type 2 diabetes with or without established cardiovascular disease, while the second speaker will talk on the management of type 2 diabetic patients with hypertension and dyslipidemia. So this is data from the International Diabetes Federation showing us that in 2019, the global prevalence of diabetes is 8.3%. And we expect a rise of 51% in the total number of patients with diabetes by 2045. And in the Western Pacific region, for which the Philippines is included, we see that this is the region where you have the most number of diabetics. And in the Western Pacific region, the Philippines is one of the top 5 countries for the most number of people with diabetes mellitus. Based on the FNRI data of the Department of Science and Technology, 2019 prevalence of diabetes in the country is 8.2%, but what is staggering is that there are 29.1% prevalence of pre-diabetes or impaired fasting glycemia in the Philippines. So 1 in 3 Filipino has pre-diabetes. And this is important because, as you all know, diabetes is one of the top leading causes of death based on the Philippine Statistics Authority in 2017. So this is why it's important to put things in context, particularly the application of these clinical practice guidelines. Again, based on the IDF, the prevalence of cardiovascular disease in patients with diabetes is about 32%. So coronary heart disease risk is increased by 160% in patients with diabetes. There's also 127% increased risk of ischemic heart disease, a 56% increased risk for hemorrhagic stroke, and a 132% increased risk for cardiovascular disease death in patients with diabetes. So that translates to a 5.8 years of life loss among men aged 50 and 6.44 years of life loss for women aged 50 if you are diabetic. So collectively, cardiovascular diseases account for between 1/3 and 1/2 of all deaths among persons with diabetes. And this holds true based on the first global study to uncover the prevalence of cardiovascular disease in people living with type 2 diabetes. This is the CAPTURE study, which was conducted on a widespread scale in 13 countries across 5 continents. So basically, it just solidifies the numbers that were given by the IDF. So as you can see, the CVD prevalence of in type 2 diabetes is 32.4%, and 31.7% of those patients with cardiovascular disease, or 9 out of 10, is due to atherosclerotic cardiovascular disease, which was defined as cerebrovascular disease, carotid artery, and coronary heart disease together with peripheral artery disease. So again, that shows us the weight of problem of cardiovascular disease in patients with diabetes mellitus. And we all know that the presence of glucose intolerance, dyslipidemia, hypertension increases this risk if they are combined and when present in an individual. So this is how we did with regards to the development of the consensus statements. So for the CPG development, we used the adaptive model. The rationale for this is to take advantage of existing guidelines and reduce duplication of efforts, shortening the amount of time needed for guideline generation. It uses the AGREE tool to appraise clinical practice guidelines. And in the Philippines, the adaptive model or method was used to come up the osteoporosis, diabetes, obstructive sleep apnea, and the hypertension 2020 guidelines, again, made use of the adaptive model. So for the recommendations about anti-diabetic medications, we use the adaptive model. However, for existing recommendations on hypertension and dyslipidemia, we just adopted and used the same guidelines that were formulated for these two conditions. So this is the adaptive process that was utilized in this clinical practice guidelines. So in 2018, July, we started with the organization of the technical working group, which was composed of 5 members from the PHA and the PSEDM, the objective of which is to develop an evidence-based consensus document for Filipino healthcare practitioners that would serve as a guide on the approach to lower the cardiovascular risk of individuals with type 2 diabetes. This was done because there were no local recommendations yet regarding the issue. And of course, the intended audience for these guidelines are healthcare practitioners managing patients with type 2 diabetes. And these are the clinical questions that we'd like to answer in this clinical practice guidelines, and we'll go through each of these one by one later. And these are the clinical questions on hypertension and dyslipidemia that pertains to diabetes that again will be discussed later by the second speaker. So these are the inclusion criteria in the adaptive method as we go through the clinical practice guidelines. So these guidelines must be about diabetes in the outpatient setting, must be published, written in English or with English translation, published in the last 5 years to ensure that the evidence is current. And in the case that the guidelines has been updated, then both the original guidelines and the updated one will be retrieved and reviewed. Only evidence-based guidelines will be included, and only national and international guidelines was included in this clinical practice guidelines. So we included duplicate guidelines, those guidelines commissioned by or published by health maintenance organizations, guidelines without multidisciplinary or stakeholder input, and guidelines published without references, as the panel needed to know whether a thorough literature review was conducted and whether current evidence was used in the preparation of the recommendations. So the agreed-to instrument, okay, was used to appraise the guidelines as recommended by the adapted. So we went through the literature search and appraised using the agreed tool, as we mentioned, so that another 5 articles from the 19 articles were removed after appraisal due to poor methodologic quality, especially with regards to the rigors of development, leaving only 14 guidelines that were included in the CPG. Eventually, draft statements were generated. Then expert panel voted anonymously using a 5-point Likert scale, and revisions were made accordingly. So we now go through each of the consensus statements on the choice of anti-diabetic drugs for individuals with type 2 diabetes. So the first clinical question was, what is the first-line anti-diabetic drug for individuals with type 2 diabetes? And the recommendation is the preferred drug for monotherapy and as base drug for combination therapy for the treatment of hyperglycemia among individuals with type 2 diabetes is metformin. And these are the summary of evidence for statement 1. So consistent with and across the different guidelines that metformin is the preferred first-line drug for type 2 diabetes. In the 2012 Unite for Diabetes Philippine Practice Guidelines, they recommend that for persons with type 2 diabetes, initiate treatment with metformin unless with contraindications or intolerance, such as diarrhea, severe nausea, and abdominal pain. So monotherapy or combination as initial therapy will be dependent on the baseline HbA1c. If the value is more than 9, then combination therapy may be initiated even at first diagnosis of type 2 diabetes. For the Canadian guidelines, a value of more than 8.5% may need combination therapy. So whether as optimization from initial monotherapy or deciding to start with combination therapy right away, metformin should be continued as background therapy and used in combination with other agents, including insulin, to be able to reach glycemic target. So ideally, it should be increased at an optimum dose of 2,000 to 2,500 milligrams per day. And within 3 months, if targets are not yet achieved, not less than 7 or 6.5, then metformin can be combined with other agents. So the next question is what to combine, okay? What to combine with metformin will depend on the following: baseline characteristics, HbA1c and symptoms, patient profile, social support, patient preference, and cost and access. So that no matter what the considerations are, the hierarchy of preferred drugs in the various guidelines always begin with metformin for several reasons. Because of one, efficacy, safety, suitability, and of course, cost. So efficacy because it can lower HbA1c by 1 to 2%. It has a low risk for hypoglycemia, and robust CV safety in the UKPDS has been shown with metformin. It is suitable for most patients with type 2 diabetes, including CKD, because it can be used for those patients with stable EGFR of more than 30 mils per minute, but should not be started in patients with EGFR below 45 mils um, per minute. So for the clinical question number 2, for persons with diabetes and established atherosclerotic cardiovascular disease, what are the anti-diabetic drugs of choice? So for the second statement, for persons with diabetes and established ASCVD, either a GLP-1 receptor agonist or SGLT2 inhibitors added on top of metformin is recommended to reduce the risk of major cardiovascular events. If either a GLP-1 receptor agonist or SGLT2 inhibitor have been given and target blood sugar has not been reached, a combination of these two agents may be considered. So in this case, established atherosclerotic cardiovascular disease refers to the presence of ischemic heart disease or documented coronary artery disease, cerebrovascular disease, stroke, and peripheral artery disease. Most of the guidance reviewed discuss outcomes related to CAD, IHD, and stroke with limited data on PAD. There are related compatible conditions with clinically significant atherosclerosis, and these are the conditions listed. So again, what are the evidence for statement 2? In the UKPDS trial, 7.5% of subjects with established ASCVD that were studied, okay, metformin significantly reduced the risk of myocardial infarction and total mortality when compared to conventional treatment in the UKPDS. And the follow-up study with additional 10-year follow-up consistently proved this observation. In a meta-analysis in 2019 of 40 studies involving more than 1 million patients with CAD, it showed that metformin reduced CV mortality, all-cause mortality, and incidence of cardiovascular events. And effects were significant even when subgroup analysis was done in patients with history of MI. So I'll be showing you the different forest plots showing that benefit in this meta-analysis. This is for cardiovascular mortality, comparing patients on metformin on the left and no metformin therapy on the right. So again, that shows a significant benefit for CV mortality with metformin, as well as all-cause mortality with metformin versus that of no metformin therapy. For those patients with MI at baseline and heart failure at baseline with regards to all-cause mortality as an outcome, we likewise see benefit. How about for CV events? We also see benefit with metformin use compared to no metformin use with CV events for those patients with heart failure, but not much for patients with baseline MI. So two studies use coronary calcium scoring. Those stroke has limited evidence in terms of primary and secondary prevention of stroke among type 2 diabetes patients after using metformin. So stroke was not much of a significant outcomes with regards to metformin therapy. So how about GLP-1 receptor agonists? So the guidelines reviewed were consistent in recommending GLP-1 receptor agonists for type 2 diabetic patients with established ASCVD. And there is robust evidence for the use of these agents for cardiovascular disease prevention. There are 7 RCTs done on GLP-1 receptor agonists with non-inferiority and superiority results using 3-point MACE as outcomes. So in this meta-analysis, it showed that GLP-1 receptor agonist was able to reduce MACE among type 2 diabetic by as much as 12%. And this treatment effect was significant in patients with established but not for patients without prior ASCVD. So this is basically a summary table of the CV outcomes for GLP-1 receptor agonists. You see there on the left listed the different agents and CV outcome trials. Marked in light orange are those outcomes and studies showing significance with regards to their hazards ratio. So the risk of MACE in each component, so in this is for 3-point MACE, again showed significance, as well as for cardiovascular death in this meta-analysis for GLP-1 receptor agonists. Unfortunately, for fatal and non-fatal MI, it touched the line of nullity, and fatal and non-fatal stroke, that showed also significance that favors GLP-1 receptor agonists versus that of placebo. So how about SGLT2 inhibitors? The guidelines reviewed were consistent in recommending SGLT2 inhibitors for type 2 diabetic patients with established ASCVD, citing results of the CV outcome trial. We're all familiar with the EMPA-REG, the CANVAS, and the DECLARE TIMI trial. There's also a real-world evidence, that's the CVD Real 2, which was an observational study which involved almost 480,000 persons with diabetes in the Asia Pacific and Middle East and North America, which showed that 25% had established ASCVD, where 6% had CAD and 9% had stroke. This RWE showed that SGLT2 inhibitors was associated with a low risk of the 3-point MACE with significant reduction in both MI and stroke. So I'll be showing to you the CV outcome trials for empagliflozin, canagliflozin, and dapagliflozin, and look at the outcomes of the CVD Real 2, showing benefit or lowering of severe risk with regards to all-cause death, hospitalization for heart failure, the combination of those two outcomes, myocardial infarction and stroke. And even in the subgroup analysis, looking at those patients with and without prior cardiovascular disease, you see consistent benefit with the use of SGLT2 inhibitors versus other glucose-lowering drugs. So how about other drugs? Now, the proactive study, which made use of pioglitazone for patients with prior MI and stroke, showed a trend towards beneficial effect of pioglitazone on the primary composite outcomes of all-cause mortality, non-fatal MI, stroke, ACS, endovascular or surgical intervention for CAD or PAD, and above-knee amputation. A meta-analysis of pioglitazone among patients with ASCVD also showed that it was able to reduce recurrent MACE, MI, and stroke. However, there's an increased risk for heart failure because of the fluid retention that we see for those patients on thiazolidine diodes. How about DPP-4 inhibitors? So the different CV outcome trial listed below showed that it is safe but neutral with regards to prevention of cardiovascular disease when compared to placebo. So non-inferiority when it comes to MACE and all-cause mortality for the DPP-4 inhibitors. So how might this change in the future? So probably the future is now, because the ESC now recommends giving SGLT2 inhibitors or GLP-1 receptor agonists among patients with established ASCVD as first line rather than metformin first or in combination with metformin. So the third clinical question is for patients without established ASCVD, what are the anti-diabetic drugs of choice? So for patients without ASCVD, the initial drug of choice is still metformin, and the choice of other anti-diabetic drugs when metformin is contraindicated or not tolerated depends on the patient's circumstance. So that if you have a patient without ASCVD, a second choice will be based on patient characteristic and drug-specific effects. So as you can see here in the list, we have 5 proofs of anti-diabetic drugs that we use clinically. And the use of these drugs will be dependent on factors like if you want to minimize hypoglycemia, if you want to induce weight loss, or you want to use a drug that is less costly. Okay, so these are just some drugs that are associated with higher risk for hypoglycemia as well as low risk for hypoglycemia. So additional consideration for patients without ASCVD and high HbA1c, insulin or GLP-1 receptor agonists are recommended for initial therapy as injectable, but for patients without ASCVD but with HbA1c of less than 9%, options would include your all other agents, SUs, SGLT2 inhibitors, DPP-4 inhibitors, repaglinide, pioglitazone, GLP-1 receptor agonists, or insulin. So last is what anti-diabetic drugs are not recommended because of increased cardiovascular risk. So thiazolidine diodes and saxagliptin are not recommended for persons with diabetes and heart failure or at risk of hospitalization for heart failure. Hypoglycemia can potentially increase the risk for cardiovascular events. Thus, medications with higher risk of hypoglycemia, such as an older generation SU and insulin, should be used with caution. Okay, so studies suggest an association between hypoglycemia and CV events where there is no clear evidence for causality. Prevention of hypoglycemia remains critical, especially in advanced diseases or cardiovascular disease, including heart failure. There's a large RCT finding that type 2 diabetes patients with a history of one or more severe hypoglycemic events have 2 to 4-fold higher death rate. And of course, severe hypoglycemia may precipitate fatal ventricular arrhythmia through an effect on baroreflex sensitivity or hypoglycemia may be a marker for persons at higher risk of death rather than the proximate cause of death. So generally avoid SUs, especially those that possess higher risk of serious hypoglycemia on any non-insulin therapy. However, the Carolina, okay, study comparing linagliptin, which is a DPP-4 inhibitor, versus sulfonylurea glimepiride showed comparable CV safety of both drugs in patients with type 2 diabetes. So among the second generation SUs, gliclazide and glimepiride are preferred over other SUs as they cause less risk of hypoglycemia. So TZDs, as we mentioned, may confer ASCD benefit. However, it may cause weight gain and increased risk for heart failure. And the occurrence of heart failure was significantly higher with pioglitazone than with placebo in the proactive trial, but without increased mortality. So 5-year prospective trials in type 2 diabetes with different severe risks that assess CV effects of DP4 have been reported to date, and only sabertene showed saxagliptin was associated with increased risk for hospitalization for heart failure. So basal insulin analogs and NPH, so they are equally effective in reducing HbA1c, but analogs cause significantly less hypoglycemia. Thus, glargine, U300, and detamine are preferred to NPH. Similarly, newer basal insulin formulations like U300 glargine and degludec U100 also have better hypoglycemia profile. So in addition, premixed insulin provide less dosing flexibility and have been associated with higher frequency of hypoglycemic events. So with that, I'll be transferring, okay, the recommendations on management of type 2 diabetes in patients with hypertension and dyslipidemia. Thank you very much.